Welcome to This Explainer. Today, we're going to take those incredibly dense 2026 medical coding guidelines for diabetes and transform them into a clear, actionable workflow to protect your practice's hard-earned revenue. Listen, if you work in medical billing, you already know diabetes isn't just a simple one-and-done diagnosis, right? It's this intricate, multi-system web. So today, we are taking the guesswork entirely out of the equation. Let's dive right in. Here's a quick look at our roadmap for this session. First, we'll cover the stakes in 2026. Then, decoding diabetes types. Third, complications and assumptions. Fourth, we'll get into billing management services. And finally, number 5, documentation and audit survival. All right, let's kick things off with Section 1, the stakes in 2026. And the big takeaway here, accuracy literally equals reimbursement. We really have to start with the reality on the ground. Diabetes is one of the most reported chronic conditions in healthcare, which makes it a massive, unavoidable target for scrutiny. I mean, when a condition impacts this many body systems, incomplete coding doesn't just skew patient data, it actively damages the financial health of a practice. This isn't just about plugging in numbers to get a claim out the door. It's a high-stakes puzzle where precision is, quite literally, your only defense against revenue leakage. As coding expert Janine Mothershed points out, payer audits deliberately target diabetes claims. Why? Because even minor variations dramatically impact risk adjustment scores and final reimbursement. Basically, you have to be perfect. Moving right along to Section 2, decoding diabetes types, the core pieces of our puzzle. Think of the ICD-10 categories as the foundational blueprint of your claim. Look, every coding journey begins with identifying that central piece, the specific type of diabetes documented by the provider. You just cannot assign an accurate code if the foundational classification is murky, right? You're mapping out everything from the common to the incredibly complex. You've got E11 for your classic insulin-resistant type 2 patients and E10 for type 1 autoimmune cases. But please, don't overlook E08 when an underlying condition, like chronic pancreatitis, for example, is the real culprit, or E09 for diabetes triggered by long-term steroid use or chemotherapy. Truly, memorizing this block is step 1 to absolute coding efficiency. Now, here is a fascinating emerging trend you need to know for 2026, the clinical recognition of type 5 diabetes. While ICD-10 hasn't given it a dedicated standalone category just yet, this malnutrition-related diabetes is gaining major attention in the clinical world. Imagine a patient presenting with severe nutritional deficits that directly impact their glycemic control. When you see that documented, you've got to look to the E13 other specified diabetes codes, and you need to ensure the nutritional deficiency and the corresponding treatment plan are explicitly clear in the provider's notes. Staying ahead of clinical classifications like this, that's exactly what separates a good coder from a truly great one. Which brings us to Section 3, complications and assumptions, where we actually connect all these pieces together. Once you have the diabetes type nailed down, you have to connect it to its bodily complications. And I'm going to give you an insider tip right now to keep you out of trouble. Completely discard the old controlled versus uncontrolled myth. Seriously, toss it out. In the past, coders relied heavily on those two subjective words. But in 2026, your code assignment absolutely must reflect actual clinical manifestations. Let's say a patient comes into the clinic poorly controlled. Well, you need to dig into the notes for specific documentation of hyperglycemia, which points directly to E11.65 for type 2. Conversely, if they're crashing with hypoglycemia, you're looking at E11.649. Always, always code the clinical reality, not the subjective label. Now, here is a CMS official guideline that is basically a massive shortcut for combination coding. ICD-10 assumes a causal relationship between diabetes and many documented complications unless the provider explicitly states otherwise. What does that mean for you? It means you do not need the provider to explicitly write out, the patient has neuropathy due to their diabetes. The system is literally built to do that heavy lifting for you, linking the systemic disease to the local manifestation by default. Just think about the bodily systems affected. If you see kidney disease, neuropathy, retinopathy, cataracts, or circulatory complications in a patient's chart, ICD-10 automatically assumes they're caused by the diabetes. You must use a combination code to capture that severity. The only exception, if the provider goes out of their way to explicitly document a totally different, unrelated cause for that specific complication. But otherwise, you combine them without hesitation. It's that simple. Let's look at an example. Chronic kidney disease requires a mandatory tag team approach. First, you report E11.22 to establish the diabetic connection. You're essentially saying, hey, this is type 2 diabetes causing kidney disease. But you're not done. You must assign an additional N18 series code to specify the exact stage, like N18.30 for stage 3. Leaving off that second piece is a guaranteed way to stall your claim. It vastly underrepresents the patient's severity and frankly puts a serious dent in your reimbursement potential.
Let's pivot a bit and move to Section 4, Billing Management Services, which is truly the future of care.
Beyond your standard evaluation and management visits, we need to ask, are you actually capturing the future of remote care? Because so many practices are leaving substantial revenue on the table by ignoring specific G codes for individual and group diabetes self-management training. These codes are essential as patient education becomes more and more intensive. And please, don't forget medical nutrition therapy. Codes 97802 and 97803 are absolutely vital, since diet remains the primary cornerstone of intervention. Capturing these ensures you're fully compensated for the really comprehensive care your providers are delivering every day. When it comes to continuous glucose monitoring, try to think of your coding as a chronological journey of the patient's experience. First, the patient gets 95249 for their initial personal setup and hands-on training right there in the clinic. Next, 95250 covers the actual placement of the device and the invisible continuous data collection happening in the background over several days. Finally, the provider's hard work analyzing and interpreting all those hundreds of glucose readings to adjust the care plan, that's billed under 95251. It's a complete story, right from the unboxing all the way to the clinical insight. Similarly, remote patient monitoring requires a flawless sequence, especially as care continues to shift away from the clinic and directly into the patient's living room. You start with 99453 for the setup and education. Then you move to 99454 for the device supply and the ongoing data transmission. And then you capture the time-based treatment management codes, starting at the first 20 minutes with 99457. Missing just one code in this chain? That means your practice is doing uncompensated work, essentially giving away incredibly valuable clinical oversight completely for free. No one wants that. And that brings us to our final stop, Section 5, Documentation and Audit Survival. This is your ultimate shield. Consider this your bulletproof survival checklist, because honestly, selecting the right code means absolutely nothing if the underlying documentation can't hold up to an auditor's magnifying glass. If the provider's notes don't clearly state the exact diabetes type, the hyper or hypoglycemia status, and the severity of complications, your claim is highly vulnerable. And you absolutely must hunt for those Z codes. If a patient is on long-term insulin, leaving off Z79.4 is a critical error that drastically misrepresents their risk profile. The exact same thing goes for long-term oral hypoglycemics with Z79.84. These codes are what paint the full, accurate picture of the patient's clinical complexity. You have to pay special attention to these frequent traps. Are you unnecessarily splitting combination codes? Did you ignore a presumed relationship, like diabetic retinopathy, simply because the doctor didn't explicitly link them in the sentence? Let me tell you, auditors are explicitly looking for these exact scenarios. Missing a CKD stage or forgetting an insulin Z code will lead directly to lost reimbursement and failed audits. It's all about building an absolute fortress around your claims so they are completely airtight. As we wrap up this explainer, I want you to ask yourself a tough question. Are your current documentation practices truly ready for the 2026 shift toward value-based reimbursement? Or is it time to overhaul your workflow? Precision in diabetes coding isn't just about passing a compliance check anymore. It is the absolute lifeblood of fair compensation for complex chronic care. So take these guidelines, look closely at your recent claims, and see where you can tighten up your process. The tools are all right here. Now it's time to use them. Thanks for tuning in.